This is what the KMA is. Let's speak to the president of the Kenya Medical Association, Dr. Jacqueline Kitulu. Good morning, Dr. Ari.
Good morning. Thank you for the invitation to your show. Thank you.
Asante sana. Welcome to the Situation Room.
Thank you.
Now, you've just heard me reading part of the statement that you released last week.
Yes.
And we are talking about the government's capacity to test, and therefore you're recommending that they change strategy.
Thank you very much for that question. So the Kenya Medical Association has the Kenya Medical Association COVID Response Advisory Committee that meets weekly. Mm-hmm. And the essence of this weekly meeting is to input into our COVID, the country's COVID response strategy. So indeed, we view the situation as it progresses and really anticipate also what we should be doing going ahead. Mm. Now, and indeed you have read our statement, and we have been analyzing the testing situation. And in our meeting of last week, in which we had representation even from the testing team from KEMRI, we scrutinized what we are doing on testing. And the greatest problem is indeed the commodities, the testing kits, the collection kits. We do not have enough of those. And therefore, it limits how much we can test. So if we're looking at the testing numbers, right now, as of yesterday, we had tested 97,340. This is for a population of 50 million people. Mm. So you can imagine, let me give a comparison. South Africa has tested about 898, they're going to almost 1 million tests.
Yeah.
Ghana is at about 200,000 tests. However, if you look at them and also look at how many cases they've picked up, they're also very different. So when you're looking at the models and what you extrapolate from your testing, you can't literally say that we'll be the same as South Africa or we'll be the same as Nigeria. So if we come back to our own country, we have confirmed, yes, we do not have the capacity to go to test and get the results as we would like to get them. Indeed, the strategy everywhere is test, isolate, treat,
Yep.
The ones that you find positive.
Yeah.
So, but looking at what we have to be dynamic about what we are and what we can do. And that is why we're saying, let us rethink this strategy and probably step back. And the strategy be then test for a reason. We have been testing, there's been the extended targeted testing. We have just gone into the community. Are we getting what we need from such tests? Maybe not. Really right now what we are saying with the few kits that we have and on hand, let's then test for a reason. And that is why we are saying, then test in the health facilities, test those who have a symptom. That's one way to use efficiently the few resources that we have. Mm. We have right now gone out into the community and created a major backlog of tests, which is now not really changing anything. It's not changing the spread. It's not changing how we are presenting. As we stand today, there's a backlog of over 5,000 tests. There are no kits as per the weekend. We didn't have adequate kits. So we are then saying that even when the kits come in, the first thing will be to clear backlog. So are we really moving forward? So moving forward, we are suggesting, let us change our strategy and test for a reason.
Dr. Kitulu, sorry, if I can come in here. One of the reasons why I think they went into targeted mass testing, and you can stop me here if I go wrong, is that they wanted to get an information footprint of the country and see where we were. That would then be able to fuel decisions that they made for things like curfews and for things like trying to essentially flatten the curve, if we can go back to that lingo, and then curb transmission, right? So are we saying then at this point, because of the fact that we don't have adequate material now to the nitty-gritty of the testing kits, if we don't have that, then fueling that information then is not necessary. What we should be focusing on is the few who may get sick, and the purpose of testing in this case is to treat those individuals and get them well, as opposed to having information footprint of the entire country and where we are COVID-wise.
Okay, so information footprint, and thank you for that. Information footprint is critical, but it must be, you'll only get information footprint with adequate data. You cannot get footprint without adequate data. And that data you'll only get by the testing. We've already come to the point that we don't have enough of the kids to get to test in numbers as large as we need to give us adequate data. So do we then sit down and give up? No, we don't. We think back and change our strategy and say, okay, let's test with what we have. Let's get the most out of it. And in that case, we are saying then get those who come into a health facility, have a symptom, or those who present with certain symptoms, get those, identify them, treat those. Of course, there are certain other people who also we must test, like the truck drivers, and that the evidence has come very clearly from testing. And remember that COVID is a disease that is transported. It's moved from one place to another. It doesn't, if you move from A to B with it, you will move it to the people there.
True.
And with that, we have evidence with the truck drivers. They are moving the disease. And those who are tested, we found high numbers, as I'm sure you've seen with the presentations on daily. So those are a team to test. A team like the hotel workers, that just distorts our strategy. The hotel workers just create the backlog. And what are they doing for our testing strategy? They're not telling. So, there are things that we have to step back and rethink. What are we doing with the few resources that we have? Of course, when we talk about strategy, remember, the strategy can only be dynamic. It can't be stuck in one place. If in the next 1 month or 2-3 weeks we have an oversupply of kits, then of course, by all means, let's test all through. But right now, as we are, the PCR testing, which is indeed very sensitive, very specific, but it's time-consuming. So if you have few kits, use them most efficiently. The information in the community, that we must get as well. But maybe this is the time then to rethink what tests do we do in the community. The antibody tests, which we have not yet, which have not been validated in the country, that might be a better strategy to test in the community and assess in which areas we need to do more testing and we need to put in more stringent measures. At the moment, testing within the community, as we are doing with the few kits that we have, does not give us value for what we have.
You know what you say, what you're raising is actually very strong arguments. And, yes, the reality of is that we do not have sufficient testing kits. Our testing capacity is severely dented, based on what we had expected that we would be testing, the numbers we'd be having by now. But then if we say that we take it back to the testing those that we must or we need to test, what does that do to the national psyche? If you're no longer, if you're only talking about people who have come to hospital and tested positive are X number of people, and other people who are not coming to hospital and not even presenting with symptoms, so they're not even coming to hospital, we don't know. Are we not going to the Tanzanian model where it's basically if you come to hospital, you tested, that's when we know that you have COVID and we deal with you?
Well, and that's why we're balancing it with the bit of when we say that if you're going to test in the community, take a different strategy of testing perhaps by antibody tests. Remember, antibody tests will not tell you that I am infected now, but will tell me about exposure. So if we are tested, and remember that's a test that is very rapid. It's simpler. It will give you a lot of information that can guide then what you want to do with that particular area within the community. So we are not saying we do not want to get the information in the community. It is key to get information that then gives you evidence for which you can make certain decisions. And I think that's the point where we started in the beginning. Just, saying decisions about extending lockdowns or reopening or things like that. You do need evidence. So if you're testing within the community with antibody tests, for example, which are simpler, which will probably be cheaper, then you will still get information, and then you utilize your PCR kits, which are few, to test then those that you really need to test. For right now, what we are doing is we have very little resources, and by the way, this is not unique to us as a country. I think you've noted that the challenge globally, even at Italy when it was at its peak, Spain when they were at their peak, They had to make a decision. If you are sick, we shall test you. If you have symptoms and you're not too bad, just stay at home.
Yep.
Because, the kits are, everybody, each country in the world wants those same kits. So right now, then, with what we have, how do we best use it? That is what the reason behind our recommendations. Not that the testing is not useful, not that it doesn't give evidence, but what can we do with the few kits that we have at present? How efficiently can we use them to get better data to make decisions that are impactful, rather than, in a sense, testing. I'll go back again, testing hotel workers. What is that giving us in terms of information to change our strategy as a country? Not much.
Dr. I'd like to ask this simple question.
Yes.
What influence does KMA have on government policy on health matters?
So the Kenya Medical Association, as the umbrella association of doctors and dentists, has as the lead healthcare professionals, we are members of the Ministry of Health COVID Task Force response team. We are represented as the frontline healthcare workers, and sitting in various capacities. Our members are members within the various ministries, and so the information that we generate indeed does reach these areas. We have presented within the Senate COVID response committee. We have spoken to the parliamentary team. So the information we generate does influence policy through the various areas where we sit.
So in terms of then you making recommendations or things like this, is there some kind of hope that somebody's going to pay attention to this and actually get something done?
I believe in terms of paying attention, yes, people are paying attention. But remember, at the end of the day, the decisions that are made are not based on just one arm of information. We will give the scientific information and evidence. That is our role as health professionals. And it's not anyone's role, it is ours. And we must give the information that we see best in that direction. Yeah. But there are other considerations that will be made. There are economic considerations, there are political considerations. Those I cannot speak for because I do not sit in those positions. But all those will be part of the considerations that at the end of the day, the president considers and makes a decision. So it is incumbent on us as health professionals always to give the scientific evidence and information that must feed into that process of making policy decisions.
Why do you think it is, Dr. Kitulu? Why do you think it is? Because I sit here and I may be baffled a little bit that there seems to be, there is a shortage of testing kits in this country, and still insisting on targeted community testing, there's still a backlog of results waiting to be established. So why do you think there's the continued insistence on targeted community testing?
Well, I think, in a sense, you start, and when you're looking at the strategy, and I'm stepping back here to look at the various countries and the different strategies they have taken, and when I observe, what I see is that there's been a continuously changing approach to managing the COVID response in various countries. So each country, you analyze and look back and say, okay, what do we have and what can we do? So, and what is that influenced by the modeling that's done by various scientific teams and the different inputs that you're getting. So at the moment, I think the strategy we had taken was based on the models that had been done, and that strategy seemed to be the way to go. But we're saying now where we have reached, maybe this is a time to have a change because it is not giving us what we need from it. And I don't think that in a sense is a point to fault anyone, but it is a wise thing to do, to sit back, regroup and re-strategize.
It's reacting to the reality.
we are reacting to the reality. You have to work with what you have.
Okay.
I think initially we presumed that a certain number of kits would be available, and that has not come to pass. Even the kits that have been availed, and that's what the testing team said, at the moment what we had, many of them are manual kits. Those require a lot more human resource than is available to run them. The automated kits would run much faster, but there's less of those available. So it goes back again to other challenges which we have raised in the past, that we do not have enough healthcare workers of all cadres, not just doctors, not just nurses. But we at this point in testing, we're talking about laboratory personnel.
Yeah.
We do not have enough of those. That's another issue you need to deal with. That if you want to get the results you want, then you must recruit more healthcare workers. Because if the kits are manual, you need a manual force to work on them. So,
it sounds like 1 + 1 = 2, Terry, but sometimes it's not as simple as it.
As that. Absolutely.
We are severely exposed. This COVID-19 is not a good thing. It's exposing so many of our cracks and our weaknesses.
It definitely is, and actually, when we look at it, it brings to the front stage the many issues we have raised in the past. We said we don't have enough healthcare workers to deal with the regular issues that we have. So when you bring in COVID-19 with the new challenges it creates, even in terms of our supply chain, the equipment, the infrastructure, all those things come glaring out. But critically right now, what comes glaring out is that need for healthcare workers.
But actually, is it that we don't have enough healthcare workers, or is that the government has not employed enough healthcare workers?
I think, well, for sure the government has not employed enough healthcare workers, but even the numbers are not adequate. When we are talking about, let me use doctors because that's where I come from. We have 13,000 registered doctors for a population of 50 million. They're definitely not enough, and they are not all employed, by the way. So both those occur, that we don't have enough, but also not enough are employed.
So we are not producing enough, and we are not employing enough.
And we are not employing enough.
Even those that we are producing.
So a situation such as this, where you need more, glaringly, like, for example, you have an area where several people have been exposed and they have to be, their healthcare personnel have to be quarantined, then the gaps even become more glaring. So it is something that we'll keep on repeating and saying we need adequate numbers to be recruited and continuously trained to ensure that we can get the quality healthcare that we desire for this country.
Well, looking at, the process and mechanics of all of this, and then if we enter in the element of behavior from the general population, who at the end of the day is needed in all of this, and if the recommendations that you've put forth as KMA, for example, to say that, let those who present with symptoms be the ones be tested, by virtue of the fact that this is what we have in terms of kits as a country, or let health workers then be the ones who are continuously tested because of their, proximity to those who may be infected. There is the attitude that we can't ignore, that a lot of people will still stay home with their symptoms. We've seen this being the case over the last few months, that even if people present with symptoms, because of what is likely to happen or where they're likely to go, they will not present themselves to hospital. Now, throw in the home care protocol that was quasi-introduced last week. People see the option of, okay, I can actually take care of myself at home. Then are we looking at an opportunity, or are we looking at the likelihood of people actually taking themselves to health centers to be tested, or staying home with their symptoms?
So indeed, those are valid questions that you raise there. And it goes back to the communication strategy. And there has been great attempts in terms of communicating what needs to be done with COVID. But behavior change is sometimes not directly proportional to the amount of communication that you give. And I think we've seen this in even all the time, way back from the time of HIV testing. But that then means that is a point we need to re-emphasize. The greatest worry initially was, yes, I'll get tested and then I'll be taken to quarantine into a government facility where I'll be stuck and, I'll not be able to reach my family. and I'll have to pay.
Yeah.
So, I mean, that's one of the recommendations we kept on making earlier on, that those who are taken into a quarantine facility, the government needs to pay.
Yeah.
When it's a public health, you're doing this as a public health measure, the government needs to pay.
Yeah.
And indeed, that eventually it came to pass. The government passed it very clearly that indeed, if you're taken into quarantine, the government will pay. So of course that calms down people and say, okay, I'll be taken care of. If I'm positive and I'm taken to a public facility and for isolation, the government will pay. So that then encourages people to step forward. Now, even with all these various protocols that we are saying, and you've talked about the home-based care, it was always part of the strategy that if we get to a point that where we'll not be able to take care of everybody in a facility, then what do we do at home, But that requires proper referral systems, which again go back to this same healthcare system we've been talking about. That you need to, because even at home you still need a monitoring system. Who is going to monitor this? You're recruiting, you're bringing in the public health officers, the nursing officers in the community, the rural health teams, the community health workers. Somebody needs to synchronize that. So again, it goes back to the stability of your healthcare system. And really, I'm hoping that with what COVID has revealed, that we can build back better our healthcare system. That these gaps that have been exposed, and we have known about them, that this is the time to make them better.
But for now, Dr. Kitulu, now that the government is talking about rolling out the home-based care, are we ready to roll out the home-based care?
In terms of the protocol that has been shared
on paper,
it is that has. Well, everything starts on paper, and then there's the implementation of it. And you will never know what you can or cannot do unless you step into it and test what you have put on paper. When we started at the beginning of in March, when the quarantining issue came up, we had, I think, as a country, had never done that.
Yeah. True.
But stepped into it, difficult as it was, steep learning curve, learned what needed to be learned, and moved on with it. So right now we are at the point where the public hospitals, let's talk for Nairobi, Bagathi, KNH, the KU Teaching Research and Referral Hospital are full. So what do you do? You have to rethink the strategy, and this is where I'm saying,
but I thought it was part
right
of the
from
strategy.
The beginning, step back and re-strategize.
Dr. we were discussing this earlier, and it's good that I know that KMA is part of the task force. I thought initially part of the strategy was you shall have isolation facilities in boarding secondary schools and primary schools, because people don't need to be in KNH when they're 80% of them are completely asymptomatic. The whole point is to remove them from the community.
Absolutely, and so the various strategies that have been discussed along the way. Indeed, one was isolate in a hospital setting, but then again reviewing the data and looking that more than 80% of those who have turned positive are actually asymptomatic or very mildly symptomatic. Then the next discussion is have institutions where they, in a sense, it's to isolate, and without the necessary expense of holding someone in a hospital. So, of course, hospital expenses are high. You have healthcare professionals in there who have to be paid. There's the cost of keeping a well person in a hospital cannot be compared to keeping a well person in an institution that is not a healthcare institution. And, of course, what that does to the healthcare institution is that you also limit treatment for others who have a whole lot of other illnesses which have not stopped just because COVID came about. So that goes back to one of the other recommendations that we had made. Identify facilities for COVID treatment so that we can free up the rest of the health system to deal with what it must deal with. Right now, people are fearing going into hospitals because they think,
there's COVID in the hospital.
There are COVID cases in the hospital, so I don't want to go. So a few months from now, we are going to be dealing with complications of various health conditions, which would have been managed if persons had come to the hospital sooner rather than later. So that demarcation and clarity needs to be there. So if you say this will be the COVID treatment center, this can be an institution where we can isolate those who are positive and asymptomatic. Now the next stage is those who are positive and asymptomatic and are not at risk of severe illness, such as they don't have comorbidities, then, can we look after them home? Do they have the ability to, to stay at home and just isolate from a home setting? And then we can follow up within the referral system and just retest at the end of say, a 14-day period and just ensure that they are now clear to get back into the community. So all these are dynamic strategies that have to be used together if we are to get the best of what we have.
And the reason I'm raising this question, Dr. is because now I'm seeing that the government's push is to quickly adopt the home-based care. And it appears like you've skipped that other step, which is what had been discussed previously, had been adopted, that what we shall do is we shall move from hospital into institutions and then mix institutions with home. Now, we are not having any conversation about institutions. We are moving straight from hospital to home. And I'm wondering whether, first of all, what's informing that skip? And secondly, do we have the capacity to manage home-based care?
So, as far as I have been involved within the task force team, that other institutional bit has not been skipped, and actually the discussion was about using the KMTCs in the counties that are hotspots as the institutions for the isolation. Because even as we say they talk about the home-based care, we have cautioned that yes, there are places where home-based care is not tenable. Yeah. If you live in a two-room house and there are 8 people in that home, how far can you isolate? So indeed, the home-based care may not be tenable for everyone, and we have indeed seen from the data that there's a lot of clustering of disease in homes because if you're all in close contact, then you'll have the mother will be positive, then the husband, then the children, and it moves within that circle. So that option still must be a consideration. In fact, within that institutional consideration has also been the discussion of the community isolation centers, so that like in the informal settlements that can identify a community, an area where the community can have those who are positive isolated, and they can be supported in terms of their basics. Because if you're there, you need food, you need water, you need all the other basics, but supported by the community without necessarily having you in hospital. So all those discussions are ongoing, but indeed I will not speak for government as I am not government, but I know that those are still discussions that have been held and are supposed to be part of the implementation.
Dr. You mentioned that KMA is well represented in many arms of the government, especially including the Senate and Parliament. Now, when you make presentations such as the one that you rolled out recently and say this is what we intend to do, this is what we hope to do you follow it up with any advocacy and activism, or is it just once that document is produced, you wait for the bodies that have been presented with this to respond?
Activism. I like that question. I think our strategy has been more to work within the settings in which we sit to influence a policy where we are, rather than necessarily the classic activism that you mentioned. But sitting on the policy table and being able to present the evidence we give as health professionals at levels that influence policy, such as a Senate, such as Parliament, I think those are really critical. You can shout on the street, but if you don't sit where the policy table, on the policy table, then I think you're much farther from influencing the policy than when you sit right there.
But you see, Dr. Activism doesn't necessarily mean that you hold press conferences,
you picket
and you castigate. It basically means using those platforms that you have access to, but pushing.
You push that agenda vigorously.
So you're sitting at the policy table, but on a regular basis, you're basically coming in to have the conversation at the table, have back channel conversations, so you see that you can influence your position.
Absolutely, and I totally agree, and that is part of the mandate we have of the KMA COVID Response Advisory Committee, that we, on a weekly basis, engage on what are the matters and influence wherever, at all the policy areas that we sit at, or where we can actually ask to present at, so that our voice is constantly being heard. We are not sitting back and forgetting, and that's why we meet on a weekly basis and actually set out an advisory on a weekly basis and follow up the advisories that we have made. Where are we getting? And we are ensuring that they are reaching at all these places. We are not sitting back and just writing them and going back. Even this forum that you've given us by inviting us, this is part of it. This is part of the advocacy.
So we'll talk about more of the advocacy if you allow us to take a short break, take a look at traffic. You constantly keep talking about our capacity in terms of healthcare personnel across the board, from doctors to all other cadres. You also talk about our capacity in healthcare. Even preparation for such COVID-19 pandemic, for example, has exposed us heavily. In other places that you sit includes the NHIF, where KMA has a slot on the board of NHIF, right?
Yes, Eric.
And you are the one that sits on this board.
Yes, I do sit on the NHIF board representing KNM Medical Association.
Now, recently we've seen a lot of issues coming out in the media on NHIF, the management, in terms of how NHIF is managing its resources, it's managing the money that it collects, it manages the money that it pays out, and the schemes that it rolls out. And there's been, a lot of questions on the board's role when you have issues of mismanagement cropping up at NHIF. What do you do on the board of NHIF as KMA to ensure that you have proper management of the fund?
Okay, so Eric, you've hit me with that one when we're discussing COVID, and we were discussing COVID, so we've sort of gone on a tangent. But
actually, it isn't a tangent, because sooner or later, COVID is going to come. And remember, COVID has done something that no political policy has ever done. It's shown us the underbelly of our inadequacies. And the health sector has felt the brunt of it. Now, the one safeguard that the common mwananchi has is NHIF.
Yes.
And the biggest strategy of the government in rolling out universal healthcare is NHIF.
Yes. Absolutely. And I think for me, having sat on that board now for 2 years, I have been able to literally see exactly what NHIF does in terms of healthcare provision, or rather enabling people to access healthcare. And I have been able to go around, as part of the board in terms of seeing the various branches and facilities and looking at the impact of NHIF. And I can assure you, if NHIF collapsed today, our health system will collapse. Because payment for healthcare services, even in the private facilities, public facilities, is more than greater than 50-60%, some of them by NHIF. So in terms of transforming and increasing access to healthcare, NHIF indeed is the vehicle to do that. And ensuring then, therefore, that it has efficient policies that can ensure that it delivers on its mandate is critical for everyone. And that has been, I think, for us as the board, one of the issues that has been at the forefront of the strategies. Of course, this is coupled with what the committee on reforms in NHIF, the work that they did to transform it into a suitable vehicle to deliver on the president's promise for affordable healthcare for all, the UHC. So that is absolutely critical, and I agree with what you said, that this is what needs to be. And for us, therefore, as members there, that is to ensure that in terms of governance, in terms of the strategies, in terms of ensuring that the policies we set out, the programs that are set out by NHIF, that they meet this mandate. at the moment there is there's a strategy then to implement on the task force task force recommendations for transforming NHIF into a strategic purchase and therefore to deliver on UHC. That is ongoing. Of course, we have a new team in place in terms of a new CEO, but all that I think are going a long way towards achieving what will be required to achieve UHC. I must hasten to add, we have a lot of fantastic people within that organization.
Yeah.
And if those policies, as we have been set up, are put into place, I think NHIF will be an amazing organization to work with. The private facilities, the faith-based organization, the public facilities all appreciate that. And it's just getting the system right to ensure we deliver on that UHC mandate.
What then is necessary for that policy to put into place? Because it seems that for a lot of things, across board, it is at the point of implementation that we see the problem. The great ideas and the great policies can be crafted, but then actually having something done seems to be the bottleneck. It seems to be where we stop. So what needs to happen to have now such a policy enacted to then live the reality of NHIF being something so wonderful that it could save people across the board?
There are two critical things at the moment. It's the ICT infrastructure, because a lot of what needs to be done is pegged on an ICT platform that ensures that you can reach the very many facilities, institutions, and process claims in a way that expedites the whole process. And then, of course, an organizational structuring to meet the mandate as is required. So it departs from what was previously done in many areas and going into new domains of strategic purchasing and so all those are different areas which need to be implemented, but are in the process of being rolled out.
Well, Dr. this conversation, the way you've put it, we've heard it been put exactly the same way previously. And now I just want to ask you, in your 2 years experience sitting on the board and looking at the operations, the policies, the management of the fund, what would you say was the main problem why these things never get to move to the next step?
Well, in terms of these things moving to the next step, let's take cognizance that we got that report in the last year. The task force did its job in most of 2019. And it was towards the end of the year that the report was actually presented in terms of what NHIF needs to be restructured to look like to deliver on the UHC mandate. And the implementation of which started, the process was starting somewhere around February. And then, of course, COVID happened. And there's been a lot of, of focus on COVID and limitations of movement in certain ways, but that has not stopped the process to continue being implemented. Probably was delayed a little bit, but has continued. So in terms of turning NHIF into the delivering of UHC and as per the recommendations of the task force, that is an ongoing process which started this year. So it's not been for a year that it had that mandate to transform into the delivery of UHC as per the recommendations. Yeah.
Bringing the conversation back into, as you still continue talking about NHIF and the fight against COVID-19, back into the statement that you released last week, recommending that the government revises its strategy on community mass testing. There's a question that's been posted on Twitter by Dana Lila, who says the tested persons stand at around 90,000. What's the government's capacity to mobilize community for testing, and how many will be reached through health centers without hindering health-seeking mechanism? Hospitals will record the lowest turnout.
You see, again, what we are saying is not mass testing. So let's move back. We are saying with the few kits that we have, the limited resources that we have, when we are saying then those should be distributed to health facilities with the capacity to collect the samples and or conduct the COVID-19 tests across the country. So that is not all the facilities. By the time you qualify that the ability to collect and to conduct, and if you identify certain facilities in different counties, then let that be the place where those who are symptomatic are tested. In the community, then we are just not saying just having the random testing, which as of now just uses up sample kits and does not give us the information that we have out of the few that we have. The strategy we're saying then, if you're going to go into the community testing, we need a different sort of testing, not the PCR testing that we are doing at the moment, which with the kits which many of which are manual, which are very labor intensive, and then you use it up on resources where it's not really going to make much of a difference. So a different strategy for the community, and that's where we're talking about the antibody testing if we go into that direction. But with the present kits, the PCR kits, let's use them and test for a reason for those who are symptomatic. Those who present respiratory symptoms, those requiring treatment, let's use them for those. The periodic random sampling and testing in the community, let's use a different strategy to test that. And then that will influence how much more testing we need to do in certain areas.
We talked about the antibody testing previously, and we've seen other countries use this. I mean, notably countries like Senegal, where you could walk in and get a rapid test, I think pay the equivalent of $1. In terms then of being able to find what the real results are, is that an option? I mean, and then you also talked about, those protocols having not been adopted by government here in Kenya. Is it an option? Is that something that we ought to be looking towards? Because I still go to the point, I mean, just like you said, we can't make decisions without the right data, because data then informs decisions, right? And then to even go towards government activity for, again, curfew, for cessation of movement and opening up the economy and things like that. We heard the president very, very succinctly talk about the fact that we can't open up if we are not sure that we will not get more infections. In order to know this, we must test. And I don't think we can run away from that reality. So then looking at the antibody test, is that an option that perhaps the government needs to look into and say this is what we ought to use at this point, since 80% of the population that's being tested is asymptomatic anyway?
So true that is something that we have discussed and brought up several times. And I believe from the last presentation we were given at the task force response team that the antibody test kits being validated, and validated in the sense that you have to know how accurate the results you're going to get from those antibody kits are. It's one thing to say use them because they'll be easier to use and they'll be cheaper, but how accurate will be the information that you get out of them? Right. So those are being validated, and indeed we're saying that there is a use for them in terms of assessing what is going on in the community level. Remember, the antibody test will not tell you those who are presently infected, not necessarily, because the antibody test just tells you those who have been exposed to this virus, and they may have been exposed and are now no longer infected. So that, in fact, when you do an antibody test, those who test positive are actually gives you more information in the sense that, yes, they have been exposed and they are past, because if they had no symptoms, then they had the illness. Those who are negative means that they have not been exposed and are open to infection or maybe very early in the infection. Yes. So, but that indeed will give, if you go to an area where there's a high level of positivity and exposure, then it says that's an area that you need to look at other data in that community as well. What has been the in terms of within the facilities, what are the mortality patterns or morbidity patterns, what other illnesses have been going on, and you can pick up a lot more information that again will still influence where you deploy resources even in this COVID time.
Looking forward, Daktari, and from the perspective, those of us lay people, we've considered your leadership not only robust but very progressive. What would you say is the biggest success that KMA has had, not just with COVID, but in promoting good health care universally to Kenyans? That's number one. Number two, What plans do you have for the future to ensure that things that haven't been done can be done?
I think when I step back and look at what KMA has been able to do, is I think what healthcare professionals are supposed to do, speak out on what in the healthcare space, be the lead in terms of speaking out on all matters healthcare, in terms of what should direct policy, and being able to be present in all those various areas. I think that has been very critical, because as an organization, you can do very many things, but if you are not able to articulate what issues are boldly and confidently.
Yep.
And this is not with disrespect, but with the aim of ensuring that we are moving to a better situation. I think that, for me, is what I consider is successful. That we can be able to stand out there and speak to what we need to do in healthcare financing. That we can speak to what we need as human resources for health. What we need to build up our infrastructure. That, I think, is what is successful. And moving forward, I think that's, as all professional associations, and indeed KMA is a member of the Association of Professional Associations of East Africa, that is what we need to do as professionals. Ensure that we have teams within our associations, within the leadership, that can sit at the policy table and speak to what the professionals need to do. As professionals for a long time, sometimes you get totally sucked up in what it is that you do. For us, it's treating the patients, and that is exactly what we should be doing, because you don't want them to have a professional who doesn't care for your treatment, that you get better, and that there's new things that are discovered, and that will make your health better. That we need, but at the same time, we must be speaking on matters policy. So that the teams the leadership teams that go on, that they'll continuously know that is their mandate, to ensure that they are advocating for better health for the population, for quality health, not just better health, not in numbers, but quality health care for the population, for us as KMA, and indeed even for the healthcare professionals, then that their welfare is maintained, to ensure that they can deliver on that mandate. So I think for me, that is what I would like to see, even as, by the way, my term ends very soon. It should have ended in April, and was delayed, with the present situation that we're dealing. But we have elections coming up. We are also, from a governance point of view, we are not stuck in leadership. You move on to the next level and ensure the next team comes up, and we keep on building the organization.
Okay. Do you think we're on course to getting the universal health coverage up and running?
In terms of universal health coverage, I think the one thing that lacked in the past was the political goodwill. And that we now have. And I think it is very critical to ensure that we can deliver on it. And I think we are in the right place, that the policies that have been set up, and that what the political goodwill saying that we must deliver on affordable healthcare, that is a masterstroke in ensuring that we get to where we are.
Sorry, go ahead.
So I think the other elements in terms of the financing, the structure, yes, there are gaps everywhere. But once you have that political goodwill, you have the professionals on board, and you have the people appreciating what universal health coverage will do for them, then I think then you're on track to achieving it. Because then you have the people who will deliver the care on site. You have the political will to ensure then that you get the right finances to do what needs to be done. Then it's the implementation of that.
When you speak of political goodwill,
elements in place.
Yeah. When you speak of political goodwill, I'm assuming you're not speaking as just political will coming from the top, but because of the fact that it follows devolution as a project, it must then go to all parts of the country. Then are you speaking as political goodwill from the custodians of each county, being governors, being those who sit in the legislature, whatever you want to look at that will? Are you seeing goodwill coming from those individuals as well?
Absolutely, absolutely. Right all the way from the president at the top, as he speaks for his national government, but even at the county government level. That we're all aligned that this is what we want. And I think even from the county level, you've seen the counties that even have gone on to do their own UHC for their own counties, seeing the value. So that indeed those are the things that, for me, give me hope that we are on the right track, that the value has been picked up. When Makueni did this, Machakos were doing that, Kitui, incidentally, all that's in Eastern, but all those are counties that are looking and saying, this makes sense. This gives value to our people.
Right. Ever so positive of you. Thank you very much for speaking to us, Dr. Jacqueline Kitulu. She is the president of the Kenya Medical Association. We wish you all the very best as you continue working in the task force advising the government on how to fight COVID-19.
Thank you very much, Eric.
Thank you so much, Dr.